My name is Zahra Aga Khan. I am here to talk to you about a rather different animal, about another health system, but a health system that works in some of the poorest countries in the world and some of the most challenging environments in the world, and very remote communities and very difficult circumstances. So I came with my colleague, Dr. Gijs Walraven. He is the professional. I'm kind of the shareholders' representative, I guess. But Gijs and I have been working together for more than 20 years on the AKDN health system. So to give you an idea of what AKDN is, the Aga Khan Development Network is a group of agencies that effectively does what's known as multi-input area development. So when we go into a geography, we as a private not-for-profit NGO, do we have this? Yeah, no, I don't have it. We're supposed to have slides, but you know. Anyway, we're a group of agencies that does everything from infrastructure and industry to health and education. Education at all levels, from ECD, early childhood, all the way to PhD. We that one? He knows what he's doing. No, I don't.
So this is the one.
On the healthcare front, we work at every level, mostly at the village and primary level, but all the way up to tertiary hospital care. And we have other agencies that do other things: culture, economic development, tourism, media and communications, communications technology. We, for example, were the first mobile provider in Afghanistan. So that is the AKDN. Within the AKDN, we have three basic components that deal with health: Aga Khan Health Services, Aga Khan University, and Aga Khan Foundation. This is a snapshot of where we work and what we do on the health front. So you will see from the numbers on the left that it is quite a significant system. We see quite a lot of patients. And Gijs, you said it's 40% of that is PPPs, right? So we work with government in many areas. We always try to work as a best practice model, a partner to government. We do not replace government, although in some countries, for example, Afghanistan, Gijs and his team have been managing 5 provincial health systems in Afghanistan on behalf of the Afghan government, interim government, which means that the health system, our own health system in Afghanistan, went from 2 provinces to 5 provinces. And that's the whole province. So as a network of private agencies, we take on some pretty big responsibilities. My son Ili and I and Gijs were just there just last week. This is the kind of place where we work, northern Pakistan, very remote places, difficult to get to, and communities that until the 1960s, I would say, had absolutely no access to healthcare and education whatsoever. I mean, there was traditional healthcare and education, but really nothing. And in many of these countries where we work, there is no government provision. So if something goes wrong and we can't continue to do what we do, then there is no backup. We've also some of these units are quite old. Our oldest hospital was started in 1924 in Karadar in Karachi. But these are all hospitals at the secondary level, I would say, in urban areas. These units are all fit for purpose. So we provide primary care where primary care is needed, secondary care where secondary care is needed, and Gijs will talk more about the hub and spoke model that we implement. But all of these hospitals, even in the poorer areas, for example, in Gilgit, Pakistan, which is where we just were, in Bamiyan, Afghanistan, these are fit for purpose. The Bamiyan hospital, from the day it opened, has been over 100% occupancy, right? And I don't know where Dr. Walraven and his colleagues put the patients. I think they probably put them in the broom cupboard. I'm joking. But the last figure I saw for that hospital in Bamiyan, occupancy was almost 120%, which is enormous. But it gives you a measure of the context that we're working in and the need that we're facing. And this is simply in the healthcare theme. If you look at education, it's the same. If you look at nutrition, it's the same. If you look at rural development, it's the same. And that's why we try to do all these inputs together, including bringing healthcare to these populations. I think, where are we now? Yes, these are our contexts.
So when it comes to this, and Princesa Zahra already started saying a bit more about what we try to do and where we do what we do. But what we're really trying to do is to move from what is on the left-hand side to the right-hand side. And some of it you might recognize even in Portugal. But if you go to low and middle-income countries, obviously that changes completely. And how you approach that, and indeed, like Princesa Zahra was saying, we have experience for many decades of how to do that. And obviously, there are still many challenges which we are facing. And what we do in each of the countries where we work is very much dependent on the context of that country and what we are allowed by that particular government or that particular situation. So what we do is very dependent on those particular circumstances. But I think you will recognize some of it. And if it comes to patient-centered care or proactive care, high quality, sustainability, I think we all have the same problems globally. And obviously it might be different in low and middle income countries. But I think, and I'm going to hopefully, and we are going to hopefully show some of that, that there are things where higher income countries can learn from lower and middle income countries. Because all of us are confronted with a situation that healthcare is becoming increasingly unaffordable. And how do we deal with that in any country of the world, and how much resources you put in there? So, shall I continue? Yeah.
I was just going to say that I think that a question that's primary probably in most people's minds is how do we deal with 12 million patients and how is this financed? And so just as a part of this introduction, we charge fees. We're not for profit, but we charge fees. They are modulated according to the affordability of the populations that we're serving. So in poorer areas, we will do the same lab test or the same diagnostic test for a lower fee to keep it affordable for the population. And in the more affording populations, we charge higher fees. This kind of Robin Hood principle allows us to balance out the care that we provide. And what we've found is that by keeping the fees low, it drives volumes up, like consequentially up, which means that over time, the system pays for itself. And Mwanza, which is one of the hospitals that you just saw as a cluster, but Heis will get to that later, is a prime example of this. But just to give you an idea, our whole health system is 90% funded by the fees that the communities and our patients can afford to pay us. And when I say afford to pay us, we are not charging an arm and a leg, really. It is affordable to the populations that we work in. So 90% of our system is funded by user fees. Then we get about 7% from donor agencies, Johnson & Johnson, Canada, etc., about 7%, and 3% is internal funding. But just to give you an idea that this is a health system that runs in some of the poorest areas of the world and yet is affordable and accessible to the populations where we work.
And if you talk about, so these are the teams around which we work. And we equate perhaps too much health with healthcare and healthcare provision. Because obviously a lot needs to happen at what we call community and population health, to keep populations healthy. And if they need treatment, that you do that as close to the homes as possible as well. I'll talk about each of these building blocks as we go forward. And this is then some of the way how we approached it. In the center of it is indeed people. And we need to keep in the back of our mind that it is about people. It's not about the systems itself. It's about how do you orient your systems around people and the patients. And like I said already, a lot goes around, and you will see this. Obviously, Portugal is more advanced, but in many of the countries where we work, we traditionally have done over the decades a lot of work around maternal, neonatal, child, and increasingly adolescent health. But now, because we are in a way a victim of our own success, life expectancy is increasing. And you see in many of the situations in which we work, an increasing problem also of, let's say, the non-communicable diseases and mental health issues. And we are adapting and having to change our operations and how and what we do. But a lot of it is indeed at the population level, and that's very important as we build and continue to go forward. Health and health service delivery has a number of building blocks. We all know probably the 6 building blocks of the World Health Organization. And if you look here at some of the areas, again, this is about the numbers and the impact we are making in what we are doing. So it's a system which doesn't only do health service delivery, it does a lot of training and education. As you can see, via the Aga Khan University with its campuses in East Africa as well as in Karachi and also in other places, but those are the main campuses, a lot of people are being trained in the formal system. One thing I want to challenge, I think, everybody about, and that's the fact by the year 2030, there will be an estimated shortage of 10 million healthcare workers. And what we have seen over the last number of years, and it's increasing and it's a real problem, is the fact that higher income countries are recruiting from lower income countries. And a good example is the turnover of our number of nurses, which are very well trained in Karachi, that 40% moved on last year. How do you deal with that? How do health systems in lower and middle income countries deal with the fact with what you could call poaching? And of course it might be good for those individuals to move on, and they might have a benefit out of it. But the economic determinational effect of that for the lower and middle income countries is enormous. And I think there needs to be really a system where there is some level of compensation of lower and middle income countries towards compensation that the lower and middle income countries receive from the higher income countries to compensate for this loss. And that's something which really needs to be addressed. Higher income countries need to train more healthcare professionals and not be in a situation that they need to continue to recruit from the low and the middle income countries. It's a major issue. And the agreement which was agreed upon by the World Health Assembly in 2010, unfortunately, hasn't been adhered to. Quality healthcare. I'm going to come back to that, or we are going to come back to that, and I'm going to talk a bit about how you can introduce that also in these kind of contexts. And indeed, it's very important. And in our system, we have an arm called the Aga Khan Foundation. And the Aga Khan Foundation, within it, has a program which is paying attention to building civil society. And in many of the countries where you work, civil society might not be strong. So we have programs to support, for instance, medical associations or nursing associations to build their capacity and really stand up for the right thing to happen in those countries in regard to health and healthcare. We already showed this in the beginning, the sort of footprint we are talking about. And indeed, these numbers, I guess, are not small. And as already highlighted, more than 40% are public-private partnerships, which means that we manage health systems and health operations on behalf of the government in those countries, in a contracting out agreement. And we need to meet then a number of standards which are put in that contract of deliverables and outputs as well as outcomes to ensure that it happens in the right way. Like I said, quite a considerable footprint. This is something which we continue showing all the time. We feel this is very important. It is not about the hospital at the end. It's really about the community and the population and ensuring that people have access to the right information and have a say about their own healthcare. And the building of such a system, which is logical, also makes it possible to keep it affordable. This is very important. It's also being helped, and increasingly, by the fact that there are new technologies, that we can make use of digital health, teleconsultation, etc. And we are going to show you something about that. Some of the impact of this work. So here we're talking about northern Pakistan, and indeed we have just come back from there. And here you can see indicators which were in the mid-80s at what you could call baseline, which were rather dramatic. But you can also see that putting in place this health system, that those indicators can be improved a lot and can become much better than the national level. And some of these indicators can compete with high-income countries if it comes to the level of immunization, for instance. And as already highlighted, the life expectancy has gone up rather a lot, which means that we need to adapt to that situation. I think we need to be humble in the fact that we are healthcare professionals and we think we do wonderful things and we are improving the situation and the health status of people. Obviously, we have some effect, but we should not underestimate the input, and we are lucky in the case of the Aga Khan Development Network that we are multi-sectorial, that indeed adequate sanitation, improved water, education, especially education of girls, improving of livelihoods, plays an important and perhaps an even more important role than what we do in health and healthcare.
I think you're being modest there, Gijs.
Sure.
I think that the health impact is enormous. If you look at these indicators, I mean, this one is the real shocker, right?
Sure. This is Afghanistan, and you see here what has happened over a not very long period of time. The maternal mortality measured in Badakhshan in northeastern Afghanistan, that level of maternal mortality was never measured anywhere in the world as high as this. It was published in 2005 in The Lancet. And you see how dramatically you can reduce over a relatively short period of time, how you can improve both maternal and child mortality. And it is again about putting in place an affordable, relatively simple system. And what was really here, probably the most important intervention, was the introduction of community midwives. What we did already around 2003, 2005, with support of the Aga Khan University, we developed a specific curriculum. It was at that time an 18 months curriculum that would help community midwives, really train young women to be community midwives. It was after the first Taliban period. So we had great difficulty to get young women into that program who had at least some basic skills in mathematics, who knew how to read and write. And we had to do a lot of generic education as well as training them and giving them the skills to do that community midwifery. The women who came into that program were selected from within their own community. Their parents, and in some cases these women were not so young, so their husbands as well, they were very courageous to have those women go to the provincial capital and be trained in the provincial hospital, which we were managing and are still managing, so that they could get the skills to do a safe delivery. I think that has made the largest impact. In 2005, we had real difficulty recruiting the first 30 candidates who were going into that program. Just before the second Taliban regime came in, if we would put out an application for this particular course, we would have hundreds of applicants for those 30 positions. And the girls who would come in later had also much better education. They would be grade 12 leavers. They would know quite a lot if it comes to generic education, including quite good English language skills. We're obviously now facing another problem if it comes to what has happened since 2021 when the Taliban came back in August. And that's something we are trying to deal with, as you can imagine. But really, this did not cost a lot of money. You're talking about $10 to $12 per capita per person. And you can make this kind of a difference. So what has helped us? I don't know whether you know about Alma-Ata and later Astana, the principles of primary healthcare, which is based on appropriate use of resources, equity, access, and intersectorial cooperation. So ensuring indeed, coming back to the safe water, adequate sanitation, etc., etc. And I think it's still extremely relevant as we move forward that we keep holding ourselves to those principles. The other points I think are quite clear. We talked about it, in fact. So
So this was the footprint of healthcare in in Badakhshan in 2004. And since Gijs and his team have been working on it, this is what it looks like today. A hub and spoke system which is connected from hubs to sub-hubs to spokes, starting with the community midwives and the lady health villagers at the village level, referring to the spokes, referring to the sub-hubs, referring to the hubs, which are comprehensive health centers, referring then to either Bamyan or Kabul or even to Karachi. And at some point we'll talk about connections and remote and technologies.
Sure.
But this is a system that works. This is a system that keeps the lumps and bumps at the village level and refers the patients who need it all the way as far as necessary to a tertiary level hospital as necessary.
Yeah. And this shows the 5 provinces which you talked about.
Yeah. And the same goes for East Africa. This is what the footprint was like 14 years ago. And then today, this is what it is. That's what it looks like today. So again, you have a system that refers from the secondary towns, from the villages to the secondary towns, from the secondary towns to the main towns, and then onwards to the university hospital in Nairobi if necessary.
So one thing it referred to in that particular video was indeed the use of teleconsultation, e-health, digital health in general. And as you can imagine, in these kind of contexts, it's extremely useful. You saw the remoteness and the difficult to reach areas. And empowering a community nurse, a community midwife, and in the context of northern Pakistan, it's called a lady health visitor, to empowering them so that they can diagnose and treat patients in the village with the support of health workers and more specialized healthcare workers, doctors in the provincial hospital, or even the university hospital in Karachi, is extremely helpful to us. We have good data about the large amount of time as well as financial resources it saves if you do this.
And Gijs, would you add that COVID gave us a bit of a kick in that department, in that then the HDUs, the ERs, and the ICUs were all connected to the central hubs. And it allowed our staff, which very often our staff are trained in-house. I mean, this AKHS does an amazing job of training people at the ground level who stay in their contexts and who stay in their towns, who stay in their communities, or who leave and come back. But because of COVID, we then had a sort of very helpful mutual learning system whereby all of our ICUs could be managed and advised by some of the specialists in the urban context, which was very helpful.
Sure. One thing which we learned during COVID-19, in a way, we had to leapfrog. You might be aware that obviously we all had telephones in our house 20 years ago. Now we have mobile phones. In large parts of Africa and South Asia and Central Asia, they never had those landlines. They immediately went to the mobile phones. And here you see something relatively similar happening. We don't have the specialist ICU doctor in the provincial hospital, but we can link them to a larger facility, let's say in Karachi. And the whole system changed in having those doctors from Karachi advising the doctors and the healthcare personnel in these rural areas. So we have now a relatively large number of units where we have ICU or high dependency units which are really run remotely. Obviously there are local staff, but they're being advised by the specialists in the larger facilities. Similarly, we do the same for mental health. In some of the countries you have less than one psychiatrist per 1 million people. So how do you get that system going? It's really about doing the right thing at the right level. You don't always need to have the highest qualified, highest paid person to work in a particular setting. You can do a lot with what you could call task shifting, or what I would call task optimization, where you get the appropriate person for that particular setting, do the right thing. And again, I think in higher income countries, we can learn from some of those things which are happening in lower middle income countries. So other innovations, and we talk a lot about this. One thing is safe care. You might have heard about quality standards. One quality standard which is used a lot is Joint Commission. Joint Commission, and an arm of it is Joint Commission International. And I understand that there are quite a few Portuguese hospitals who are accredited with Joint Commission International. We also have some of those hospitals in Karachi, in Nairobi, in Dar es Salaam. However, it doesn't make sense in the other settings. So with a Dutch NGO, we work with Joint Commission and have adapted a tool which is similar, which is much more adapted to that particular situation in which we work. And we are now moving forward with getting quality in all of our centers through accreditation at different levels, and over time improving the quality as you go forward. And we are rolling that out and making that available not only to the AKDN facilities, but also to other contexts. Similarly, if you go to carbon neutral, I assume you have been talking about it, but we know that 4.4% of the carbon emissions are in the health and the healthcare industry. That would be similar to, and as much as, the 5th country in the world. We should not underestimate that. And obviously we have a role in relation to climate change as we go forward in addressing it and mitigate it. But the first thing, we should start with our own house. And that means that we need to reduce our emissions itself and give the good example. And with that, we have developed, again, it was not available, a tool which is relatively easy by a non-trained person to acquire the skill to measure your carbon emission as a healthcare provider. And that tool has now been adopted by the World Health Organization and has been rolled out in 89 countries. So with that, we hope to try to make a contribution not only to our own system, but the wider one. The one in the middle is an important one, and that's about health financing. Princesa Zahra already told you a bit about how we try to be sustainable and how we are relatively successful in doing that. But really going forward, it is very difficult to see how we achieve universal health coverage if we don't change the way how health financing is organized. user fees are not good for poor people. But how do you get pooling and ensuring that poor people can have access to healthcare in lower middle income countries, where a large proportion of the population is in the informal sector and not working? So how do you get your tax base? How do you ensure that indeed you get to models which make sense? We do quite a lot of work because we have the luck again of the Aga Khan Development Network having also working in the banking sector and in the insurance company to come up with new innovations and linking it also to mobile phones. So we are trying a number of things, but this is a major issue going forward. Perhaps you say something about this. It's you.
I can say something about this because with a wonderfully nepotistic hat on my head, I'm also a trustee of the Aga Khan University, which is a medical school and a nursing school. And I will say that the nursing school, AKU Sonam, has had a major impact in its environments and around the world. Actually, I think, Heis, you were telling me that of the nursing colleges in Pakistan, the deans of 53 of 60 of them are graduates of our nursing school in Karachi. So that's a huge impact. And that has an impact also in terms of research, because AKU does a lot of research, increasingly so, on nutrition, on the impact of climate change on human health, and so on and so forth. But I would also say that obviously we face a massive challenge because, just to give you one number, last year AKU had a 40% nursing turnover, because obviously everyone wants to recruit nurses. So they go to Canada, they go to the Gulf, they come to Europe. And so while Aga Khan University has a huge impact in creating very, very highly skilled doctors and nurses, we also are churning all the time, trying to keep the nurses in country, in their own locations. But in terms of research, what Dr. Walraven was just saying about, the connectivity and the digital connections in our system, with PACS, with diagnostics, with imaging, with having the sort of our one radiologist in Kisumu town managing 5 or 6 centers around the town, so we run 24/7 in that department. But that system connected to a data system is going to give us the most incredible patient mix and database of, so far, very little researched health issues in Africa, in Central Asia, in the high mountains of Asia and, well, South Asia. And so this research domain that was nascent when AKU was first formed and got its charter in 1983, so not long ago, just over 40 years ago, that research is now a massive, massive tool for improvement in the developing world. And I can't wait to see what happens in the next 10 years when we've really got these digital connections up and running and AI driving our system.
Sure. And we have some collaboration also here in Portugal.
Massive.
And we would like to expand that further.
Many partners around the world at the university and in the medical fields, yeah.
Then we mentioned already the lady health visitors and the community midwives. And that is what the next slide should be about, if I can get it back. No, it's gone.
No,
Oh, it's here. So we'll come back to this slide. We do this one first.
मंथली हेल्थ में हमारे मीटिंग्स होते हैं, स्पेशली जो प्रेग्नेंट माएँ हैं उनको हम मंथली अवेयरनेस सेशन देते हैं. उनमें मतलब 16 ईयर्स से 45 ईयर्स तक के औरतों को बुलाते हैं जिनमें कोई अनमेरिड कोई मैरिड इस तरह होते हैं, तो उनको हम बताते हैं आप लोगों ने ये चेकअप टाइम पे करना है, ये कॉम्प्लिकेशन है, ये फ़ायदा है, तो वो लोग खुद ही आते हैं. मैं एक LHV हूँ और जो मेरी रिस्पॉन्सिबिलिटी है उसमें एंटीनेटल चेकअप है, डिलीवरीज है, पोस्टनेटल चेकअप है, वैक्सीनेशन है, स्क्रीनिंग, स्कूल हेल्थ असेसमेंट और हेल्दी हार्ट के भी हम काम करते हैं। थर्ड ट्राइमेस्टर में ना मतलब 6-7 मंथ बाद
मैं अपना चेकअप करवाने आई हूँ प्रेगनेंसी चेकअप। मैं बिल्कुल मुतमईन हूँ क्योंकि चेकअप हो गया, सारे टेस्ट जो है पॉजिटिव आ गए हैं और टैबलेट्स वगैरह भी मिली है।
मैं प्रेग्नेंट थी, फिर फुल टाइम में टर्म में 9 मंथ तक पूरा रात भी मैं मतलब अकेली होती थी, फिर आती थी। बीच में मैंने 2-3 दफ़ा इस तरह कहा मुझे नहीं जाना, मैं नहीं जा सकती थी। फिर हस्बैंड ने ज़्यादा रेजिस्ट किया कि मतलब ज़्यादातर उसका सपोर्ट है मेरे लिए।
मेरा सपोर्ट ये है कि ये इसको आप जॉब समझ के आप जॉब न करें, बल्कि इसको आप खिदमत समझ के जाएं। बल्कि रात को बाज़ दफ़ा ये भी होती है कि रात को 1 बजे, 2 बजे, 3 बजे या कोई भी टाइम मेरी तरफ से जो है ना उसको कोई जो है ना इस तरह से कोई पाबंदी नहीं है कि आप ना जाएं। और रज़िया जो है ना सिर्फ हेल्थ सेंटर में जाके जो है ना वो काम नहीं करती है, बल्कि हम तो मेरे साथ घरेलू मामला और मेरा मामला ये है कि हम घर में भी चाहे वो किचन में हो, चाहे वो हम फील्ड्स में, आपको पता है कि हम यहाँ पे खेती बाड़ी भी करते हैं, आलू भी उगाते हैं और गंदम वगैरह का भी जो है ना हम काम करते हैं, उगाते हैं, तो उसमें जो है ना हम साथ जो है ना काम करते हैं।
और हस्बैंड ज़्यादातर अब ये रेजिस्ट करता है कि आप जाओ दोबारा खान यूनिवर्सिटी BSN करो, आगे जाओ। आई थिंक सो इधर इस तरह नहीं है कि मतलब औरतों को पीछे लेके जाए या आप लोग हमारे बातें सुने, हमने जो कहा वही होगा, इस तरह नहीं है।
और बहुत सारे जगहों पे मैं जाता हूँ तो किसी को इसी तरह से रात में या दिन में जो है ना किसी को उसके हाथ से कोई शफा मिली है तो वो बहुत ज़्यादा जो है ना खुशी के साथ मुझे भी वो बुलाते हैं कि जो है ना रज़िया के हस्बैंड हैं। ये बहुत सारे अक्सर में जो है ना ये होता रहता है।
You saw a lady health visitor, and there are many of those now. One of them is the head of our community health care program in Pakistan at the moment. She started off as a lady health visitor from one of these very flung rural areas, did her bachelor's degree in nursing at the Aga Khan University, did her master's degree in public health from Johns Hopkins, and went then to WHO, worked for WHO in Somalia and some other countries, and she's now back with us. So a woman from rural, very isolated areas is managing a community healthcare program and is the representative for South Asia on the Global Midwifery Council. Some of those success stories, and this is not the only one, I think we can be proud about.
I agree, Heis. We've met some amazing people in our system, women and men. I think to wrap up, Dr. Mario and Dr. Adalberto asked us to present the concept of a global sustainable health system. And while I wouldn't claim to lecture the NHS or the Portuguese health system, what we have is a mostly sustainable health system going forwards, both in terms of human resources, financial resources, and also going, carbon neutral by the year 2030, if not before. And I think that what really makes a huge difference, the key to everything, is that we are local. Our staff are local. Our care is local. our resources are local, and problems that can be dealt with at the primary level are always dealt with at the primary level. You don't get patients coming to hospital to have babies even, that is dealt with at the local level. The hub and spoke model that Dr. Walraven described has been key to that. It's key to make the health system smooth and able to finance itself at every level. So you have specialized care where you need it, but only where you need it and when you need it. I think the other thing is the commitment of the people in our system. At every level, you will meet the most dedicated people in the world who will work through the night if they have to, in sub-zero temperatures, in very low-resourced areas, very low-resourced facilities, but they do an amazing job. So going forwards, I think we have a system that should be able to work. If we can get our insurance and banking colleagues on side as well, that will help. But in order to create a system like that, there has to be commitment, there has to be empowerment, and there has to be a political will to make things work. And I think that I can say with pride that I think we have that.
Thank you.
Thank you.
Thank you.